I am sure that we would all agree that whatever the intervention we intend, be it in schools, policing, or health, what we want to do is try to ensure that the intervention is effective and does achieve desirable goals rather than causing harm. Any intervention can have an effect which is positive for the population for which it's intended. It can do nothing, or it actually can do harm. And there are many examples in our health history where enthusiasm and charismatic individuals have argued for and achieved change, only to find out when we evaluate them later that they may have caused harm for the population group that they were generally trying to help improve. So I think most of us share a view that we should be evaluating, and that what we want to be able to demonstrate is that the evaluation is effective, it's cost effective, that is, the cost of producing positive change is not so prohibitive that it's concerning, that it's equitable, that it applies to all the population groups that we're trying to reach, not just a subset. There is a tendency for many of our interventions to be effective for the upper and middle socioeconomic classes, but may not be as effective for low socioeconomic classes. And wherever possible, there should be a sense of social justice, trying to achieve change or desirable outcomes for all. In a implementation utopia, we would take a number of steps. Firstly, we would show in really strong experimental design that the intervention that we're trying to implement is effective. It improves outcomes for the patient or client group at a cost which is acceptable to the society, to the individual, and to the healthcare system. And when we've done that, and usually the criteria for that is multiple randomized controlled trials or better, for example, via a Cochrane review, then we need to develop translational strategies which are also likely to be effective. One shouldn't assume that because you've got an intervention which you've shown works, that it will automatically translate, nor should you assume that any particular translational methods, such as charismatic leaders or opinion groups or education, is effective in producing change. So fundamental questions when you're doing evaluation is, firstly, has a change occurred? And that is there a difference between what an experimental group has an outcome and a usual care or control group? Next important question is, was that change a result of the intervention and not some other factor? For example, you can put in an intervention to try to get people to exercise, and it may be that when you do that, that there's a community movement towards exercise, and the experimental group and the control group would show no differences if you had examined it. The next question that you have to consider is the degree of change significant and important to important stakeholders. When you're talking about degree of change, commonly in scientific literature, we talk about statistical difference, but there's also clinical difference. That is, that if you change somebody's obesity levels, for example, from X to Y, does that make a difference to their life expectancy or control of diabetes, etc.? A small change, while statistically significant, may not be clinically relevant. There are also other events where things are so important for the community that even very small changes, for example, in domestic violence, might be worth a considerable amount of expenditure of effort and energy in order to save 5, 10 lives. The value there is not in statistical significance, but community acceptance of an idea that we should do better in important areas. This particularly applies to low socioeconomic groups and those who have a higher burden of suffering, such as Indigenous people, where their life expectancy is significantly worse than the normal population group. The NIH, National Institute of Health, has developed what they call the Blue Highways. This is a complex slide that you're seeing, but nevertheless, it argues that the stages or the phases of research go through, firstly through basic science research, which is undertaken at the bench, then bedside research, where you do control observational studies, then you find out whether these things are effective, and then you develop interventions to try to test the ability for you to change clinical practice. What's there as T3 is called implementation science research, where the thrust of the effort is to see whether you can reduce the evidence practice gap. That is the difference between optimal care and what is currently occurring. It's estimated that if we could do this, we could make significant improvements in healthcare outcomes. A lot of people think that once you have one randomized controlled trial showing you that something is effective, then you should be doing everything that you can to get it implemented. More commonly, we accept that you don't need just one well-controlled trial. You need multiple randomized controlled trials, as often you can't replicate the findings. When you've got, say, a Cochrane review, which clearly indicates that change occurs, it's also not enough just to assume that you can use techniques like education of clinicians or education of patients or community people, introduction of financial incentives, etc. And those strategies will work to change the behaviour of the healthcare providers and others who you're trying to reach. I think Richard Grohl said it most clearly that once you've got efficacious interventions, you then need to develop evidence-based implementation strategies. That is, you need to apply the same logic when you're looking at intervention studies to change clinical practice and demonstrate that change occurred, that the change was a result of your educational or other intervention strategies, and that it was clinically significant. Thanks very much.